us over the next 20 minutes, we have Dr. Renato Oliveira, Souza, the Chief Mental Health and Substance Use Officer at PAHO WHO. We have Professor Danuta Wasserman, who's the Director for the WHO Center for Suicide Prevention. We have Dr. Andrea Hanovat Marquez, the Chief Global Mental Health Dissemination and Implementation Research at the National Institute of Mental Health in USA. We have Dr. Marya Levintova, the Program Director for the Fogarty Center, Washington. Professor Helen, Herrman, Oxygen and Center for Youth Mental Health at the University of Melbourne, Australia. We have Professor Norbert Skokauskas, who's a professor from the Norwegian University of Science and Technology in Norway. We have Dr. Yanyan Lee, the physician scientist at the Sun Yat-sen Memorial Hospital at the Sun Yat-sen University in China. We have Professor Prabha, Professor of Psychiatry at the National Institute of Mental Health and Neurosciences in India. We have Professor Norman Sartorius, President for Action for Mental Health in Switzerland. And we have Professor Lakshmi Kumar, who's a Professor of Psychiatry for the Foundation of SNEHA, Chennai in India. So I now welcome all of our speakers who will all be speaking remotely to us at our conference. Over to you.
Hello, good morning, good afternoon, everyone. I'm Renato Oliveira, the Unit Chief for Mental Health and Substance Use at the headquarters of PAHO here in Washington, D.C. It's a pleasure to be with you. Welcome to the conference. I wish I could be there with you, but due to current circumstances, this is not possible. So I'm really glad to be part of the Guyana Mental Health and Wellbeing Conference. That's a great initiative and very important, very opportune nowadays due to the challenges that we are facing. And as you are joining the conference, I thought I could take a few minutes from you to really share with you how we at PAHO see the impact of COVID-19 on mental health of populations. And I will do it very briefly, and I hope we'll have more time to discuss about that during the conference. So we know that mental health conditions place a big burden in terms of disability in our region. In fact, 1/3 of the years lived with disability in the region are due to mental health, neurological, substance use conditions, and suicide. And we also know that our region, the region of the Americas, is one of the highest prevalences of common mental health conditions all over the world. And this is previous to COVID. We also know that the countries, unfortunately, invest very little on mental health. More burdened countries have in terms of mental health conditions, less they invest. They put financial investments on mental health care and mental health services. And to make matters worse, 60% of the allocation of resources to mental health in our region goes mainly to psychiatric hospitals, which in fact is not the best strategy to cater for the mental health needs of populations. The public expenditure on mental health in our region averages only 2% of the mental health budget. So we come from a very dire situation before COVID. And I just have mentioned psychiatric hospitals. And unfortunately, many psychiatric hospitals in our region, they're also the place of human rights abuses, where people live for many years in institutions and they don't have their needs addressed. 20% of all psychiatric hospitals stays in our region exceeds 5 years. So that's the background that we have. And then we have COVID, which places an enormous burden on mental health of everyone. All of us are affected somehow. There are studies in our region showing increased prevalence of anxiety and depressive symptoms. We also know that there are some populations that are at increased vulnerability, like ethnic minorities, people with pre-existing mental health conditions, and also health professionals. So this adds into the burden of mental health conditions on populations in our region. And what we also know, and we have done 2 rounds of surveys with member states, trying to understand through a questionnaire the level of disruption on mental health services in the different countries in the region. And in the last round that we did with the World Health Organization 2 months ago, 60% of the countries reported that the mental health services were disrupted. So this is the highest proportion of disruption if you compare with other essential services. So in fact, when people need it the most, the services are not functioning. And this is due to many reasons brought by COVID. People are not able to access services in person. Health professionals that work in mental health services have been shifted to other areas or to the COVID response. And the expansion in terms of telemental health many times has not been enough. So this is just to give you a bit of a picture of the mental health situation in our region. It's never too much also to mention the problem of suicide, and the region of the Americas has the regional suicide rate that has been increasing over the years, different from other WHO regions. And some of the countries in our region have very high suicide rates, especially here in the Caribbean sub-region. So it's very important that we take the opportunity of this pandemic and think mental health from a whole of society approach. It's not anymore the work of only us mental health professionals or health professionals. Every hour, every area, every department needs to think on how to include mental health, be it in terms of promotion, prevention, care, or rehabilitation. It's again the whole of society approach that we need to be able to address the mental health needs brought by the pandemic that we will stay for some time. We already know that. We need to make mental health and psychosocial support completely integrated into the response to this pandemic. And we also need to have mental health systems that are strong enough to be able to support people when they need the most.
Dear colleagues and friends, dear Ministry of Health in Guyana and Professor Christina Hoven with her Global Psychiatric Group at Columbia University. My name is Danuta Wasserman, and I am Professor of Psychiatry and Promotion of Mental Health and Suicide Prevention at Karolinska Institute in Stockholm, Sweden. Karolinska Institute is known for awarding the Nobel Prize each year in medicine and physiology. I am also president-elect of the World Psychiatric Association, and therefore I am so glad that you are organizing this very important meeting in Guyana, as Guyana is one of the countries with the highest suicide rates in the world. I think that all of us should capitalize on 17 Sustainable Developmental Goals, which were proposed by United Nations and approved by 193 states in the world. These goals say that we need to have better well-being and health on our goal in year 2030. And of course, it is really very important to remember that among all those goals, there are goals about equality, better economic future, better industries, about clean air, land, and sea, about inequalities, about gender equalities, but the goal on health is very high on the agenda. It is the goal number 3 after goals no poverty and no hunger on the globe. And this goal number 3 about better health, and among better health, we have also mental health. They are indicators about that we need to decrease suicide rates, as well as to decrease use and misuse of substances and alcohol. We have several evidence-based strategies for promotion of mental health and prevention of suicidal behaviors. Those are summarized by Professor John Mann and Gil Saltzman already in year 1995 and 2016 with the group of international experts. And I was in that group, and I know that a lot has happened, and we have a lot of good suicide preventive and mental health promoting methods, which are unfortunately not implemented. And I really hope that this conference will give you a push both to surveillance of healthy and unhealthy behaviors influencing mental health, but also towards the implementation of evidence-based methods. In my textbook, which was published and updated this year by Oxford University Press in United Kingdom, you can find all those methods described. And I really hope that this summit you are having now in Guyana will give you a lot of impulses how to improve our implementation of different methods, how to improve the surveillance of mental health, and how to implement good methods. Thank you very, very much. And I am very sorry not being able to join you in person, but I really hope that during my presidency for the World Psychiatric Association, I will be able, together with Professor Hoven, to visit your country. Thank you very much. Goodbye.
Dear all, on behalf of Fogarty International Center at the U.S. National Institutes of Health, I would like to welcome you to the Guyana Wellbeing and Mental Health Conference. This conference will cover some of the major topics of mortality and morbidity in Guyana and worldwide. I wish all of you a very productive meeting and look forward to all of the presentations.
Hello to everyone in Georgetown and colleagues joining from other places. I am Helen Herrman. I'm a psychiatrist and public health physician. I'm based in Melbourne in Australia and working with Orygen and the Centre for Youth Mental Health at the University of Melbourne. I'm the immediate past president of the World Psychiatric Association and have also worked with the World Health Organization in the Western Pacific region in the past. I'm thrilled to be attending the Guyana Wellbeing Conference and thank the whole leadership team from Guyana and from the USA for the invitation to participate and to join in welcome to the conference. I pay special tribute to Dr. Christina Hoven for reaching out to me and others among us. The focus on suicide and related forms of harm, including trauma and violence, whether in the home or in the streets, is particularly important in Guyana, with the high rates being reported across the lifespan. But what is being discussed here will be of great importance to people everywhere in the region and in the world as well. What are the training needs and service needs to reduce the harms? And what are the partnerships across various parts of the community in Guyana that are able to contribute? How do professionals work with people with lived experience and with the carers of people with disabilities across the lifespan, as with advocates in other sectors and all sections of government. And what is the contribution of the partnerships with international groups and organisations that you're modelling at this conference? It's a great achievement to convene this conference, co-sponsored by the Guyana Ministry of Health, the University of Guyana, and the Global Psychiatric Epidemiology Group at Columbia University in New York. That one being led by Christina. And it's especially so at this time in the life of the world. I understand that colleagues from the Pan American Health Organization are also here with their wealth of knowledge and experience and their commitment to support local leadership and change. I know the proceedings will be enriched by contributions from those working on the study funded by the National Institutes of Mental Health in the United States, established by this same convening group to understand why so many lives are lost to suicide in Guyana and what can be done to reduce that loss of life, as well as the newly funded Fogarty training program with Columbia University at the University of Guyana, focused on training about trauma and in support of injury prevention. So congratulations once more, and I look forward to joining you in a wonderfully successful conference.
Hello, my name is Professor Norbert Skokauskas, and I'm a chair of the WPA, World Psychiatric Association, Child and Adolescent Psychiatry section. It's my great pleasure and honor to welcome you all to Guyana Wellbeing Conference. I'm very pleased that this important meeting is sponsored by Guyana Ministry of Health and Global Psychiatric Group at Columbia University. I would love to be together with you in Guyana, Georgetown, and to share my knowledge and experiences in person. This time, however, I will be speaking online, but I'm looking forward to meeting you all in person in Guyana in the near future. And finally, I would like to congratulate Professor Christina Hoven personally and all her team in Guyana and New York to making this very important event possible, and I'm sure it will be very successful. So please enjoy the conference and see you soon.
Good morning, ladies and gentlemen. I'm Yuyan Li. First, I'd like to thank the conference community for inviting me. I'm grateful for the opportunity to share my study with you today. First, please let me introduce myself. I'm now a postdoctoral fellow at Sun Yat-sen University in China. I'm doing clinical research in the field of the interaction mechanisms of psychosomatic disease with trauma-exposed people. During my study in the United States, I often heard Dr. Helen mention Guyana's research. She cares deeply about Guyana's children's living conditions and hopes that they can live in a better environment and have a good perspective of development. I'm very happy that I can participate in this conference and share my study with you here. I hope that I could make some contributions to the well-being of the Guyana children with you, and hope that we can do more and more cooperation that commit to promoting the development of this world in the future. Thank you.
Good morning, and I bring greetings from India. I thank Professor Christina Hoven for inviting me to this conference, which looks so wonderful. Over the next 4 days, you have a range of talks and discussions on some of the most important aspects of mental health. And this is a step towards making sure that every part of the world starts talking about mental health and well-being of the people in that country. ranging from suicide to domestic violence to COVID to aging and trauma. I'm sure you'll enjoy the next 4 days. I'm delighted to be speaking later in the conference on topics like perinatal mental health, as well as domestic violence. All the best to this conference, and thank you so much for inviting me to be part of this wonderful meeting. Thank you.
Thank you very much for inviting me to come to attend this conference. I'm saying this for 4 major reasons. Number one, I think it's tremendously important to attend a conference which is addressing well-being. In our times, very often we are forgetting that well-being is the central goal of all efforts of healthcare and of societies. And to address a conference to that is very important. The second reason is that I want to congratulate you is that the conference is organized in partnership between the Ministry of Health and the University of Guyana, as well as with the collaboration of another university from the United States. I think that the collaboration between ministries of health and university are of tremendous importance and must be promoted. Unfortunately, it does not happen very often, and it's wonderful to see it happen here. The third reason for congratulating you is that I think that the conference has brought together people with different experience and different backgrounds. And it's very important because all of the problems that the conference is addressing are in fact requiring collaboration, working together by people of different knowledge, different professions, different experience, and different positions. Finally, I think it's important also to say, and this is the 4th reason why I'm congratulating you, that this conference is happening at a time when the world is experiencing a pandemic of COVID. COVID is a tremendously important topic, and undoubtedly we should do everything we can to control the pandemic, and to help people who are affected. But at the same time, we are not allowed to forget the other problems and the problems which we are addressing, such as the problem of suicide, the problem of traffic accidents, the problems of various uses of drugs and alcohol, etc., are all problems which are terribly important and which must not be forgotten, while we are at the same time also thinking of ways in which the pandemic can be stopped and the harm which it is producing reduced. So congratulations, and thank you again for inviting me to be with you.
Thank you, everyone, for your greetings. We now move on to the next item on the agenda. I would like to introduce Professor Lakshmi Vijaya Kumar, who is a professor of psychiatry at the foundation of SNEHA. Thank you.
Thank you very much. It's a pleasure to be here and a privilege. Unlike the other speakers, thanks to Professor Christina, I am able to give my greetings in person. So again, greetings from India. I think both our countries have a very dubious distinction with regard to suicide. India has the largest number of suicides in the world. We have overtaken China in that. And fortunately, Guyana has come number 2nd. But the fact that suicide is a huge problem, both in India and Guyana, was one of the main reasons for me to come here. And as the speakers have said before, there is no single reason for suicide. Suicide is a medical problem, psychological problem, social problem, religious problem, and sometimes even a philosophical problem. So unless everyone gets together, we will not see a reduction in suicide. For example, the health services, and it is, how do I say, I've been working for a national suicide prevention strategy in India, and I've been nudging it, and it is moving by millimeters. It's 3 years now. And I hope, seeing the political commitment and will here, I'm sure you would have your national plan much before India had. And I'm very happy about it. The fact is, just as we don't have a suicidal caucus which causes suicide. We have multiple factors, so we have multiple interventions. So we have to look at it as multiple interventions. And that means collaboration and cooperation. I think this conference is will be a catalyst for everybody to come together to reduce suicide prevention, because there's this, I like the title of mental health, wellness and promotion, because when you promote mental health and improve the resilience, then automatically suicides will come down. And I think what we need to understand is that it cannot be done by one, but together we can definitely do it. I mean, if you look at the evidence-based interventions, for example, we have to work with the Ministry of Health or all the health workers. We have experience in India where even public health workers, even lay volunteers can be trained to identify, support, and refer people who are at risk for suicide. And we have to work with the Department of Education so that in schools, we teach the young children resilience and problem-solving skills. And then at adolescents, particularly in our cultures, in low middle income countries, we have to teach them problem-solving, interpersonal problem-solving skills, particularly intergenerational conflicts, which play a huge role. And then, of course, we have to address the issue of interpartner violence, domestic violence, and suicide, and alcoholism and suicide. So to reduce access to pesticides, we have to work with the Department of Agriculture. We have to work with the Department of Education, then with the judicial and law to decriminalize suicide. So we have to work with a variety of departments, and we all have to work together to make this happen. I would like to end by saying one of my favorite quotes from Mahatma Gandhi, who used to say that everyone has a right to be independent, but then it is equally important that they are interdependent. It is equally their responsibility to be interdependent. And when we work together, we can definitely make a difference. And again, what he used to say is, what seems impossible is not really always so. So we hope we will reduce suicides in Guyana, and we will have a national plan in India. So thank you
very much for your greeting. We'll now invite Dr. William Adu-Krow, who will introduce the next speaker, who will be presenting to us on the status of mental health in Guyana. Dr. Adu-Krow.
Thank you. Excuse me, Dr. Hamilton. I met Dr. Harry about 7 years ago, 6.5 years, 7 years ago. Excuse me. And the first time I met him, we had just received the 2015 WHO book on the statistics on suicide. So we were discussing with the then minister, and because I didn't have any mental health officer in my office, I decided to take that mantle. So I met with Dr. Harry, and during the discussions, he said, Dr. Adu-Krow, I have a lot of data, and I can bring that data. So it's not like we are not looking at it, we are looking at it. But then I'm telling you this story because then when I mentioned to Dr. Harry that we have this global group that is helping with suicide, you know what he said? He said, yes, we have the data, but we want to invite people who can help us fine-tune that data, make it more representative, make it more sellable, make it such that everyone will believe in that data. So this is someone who is really down to earth. Dr. Harry is a Guyanese psychiatrist. He obtained his medical degree in Havana, Cuba in 1983. Sorry, Doc, I'm telling your age a little bit. He obtained a specialist in the degree in psychiatry, also from Cuba in 1988. Dr. Harry is widely regarded as the father of psychiatry. I always call him father of psychiatry in Guyana. He has worked at the Georgetown Public Hospital Corporation since 1983 to present. He's currently head of the Department of Psychiatry at GPAC, and I'll say head of psychiatry in general for the whole country. Ladies and gentlemen, let's put our hands together to welcome Dr.
I would like to acknowledge the virtual presence of Professor Xenia Lopez Montel, who couldn't be here to take this illness, and Professor Reverend John O'Connor, who is all the way in Canada. I don't know if you can see me, but good. All right, I Halfway through Dr. Adu-Krow's presentation, I looked for the emergency exit, but as I can see, I didn't find it. I made a few points here with the hope that I do not wander off, and forget what I came to do here. Firstly, I would like to say thanks to all you good, generous people for taking us into consideration. And I am convinced that good things are going to come out of this, not only because you're here, but because of the commitment of our ministry, and government. In Guyana, usually the foreigners learn very quickly when we say just now. Just now means from now to until thy kingdom comes. Sometimes just now never happens. Okay? But in this instance, I'm convinced just now means almost now. So I thank you all. I asked somebody this morning, I said, tell me something. Status of mental health in Guyana and mental health status in Guyana, is it the same thing? And we almost had a discussion that didn't give rise to anything helpful. So I'll talk a little bit about status of mental health in Guyana. For me to do that, I would need to go back a little bit. I promise not to bore you very much, and I promise not to give you statistics that you already have. Okay? I'm usually a little bit helter-skelter. My brain is like that. But I will give you the information at the end of the day. Now, a long time ago, we had 2 wards in the Georgetown Hospital. Female ward and male ward, separated by a structure. It housed 40 beds. And during those days, we had outpatient clinics in Georgetown Hospital, outpatient clinics in Parika, Linden, Mahika, and Barnes. At that point in time, we had the National Psychiatric Hospital. That always existed, in better times and in worse times, in better conditions and in worse conditions. And if you come to Guyana and do not visit that institution, then you make a special effort to come back. Now, during those times, it's interesting to note that our suicide rate was quite low. Was it because we were not collecting data? Was it because we didn't have the social media? I don't know, but it was low, much lower than it is now, much lower. Now, over time, we have been able to reach out to communities very distant from Georgetown, very distant. If Guyana is divided into 10 administrations, we do clinics in Region 1. In Region 2, we now have a psychiatrist. In Region 3, we have 2 sites and we're opening a 3rd site. Region 4, which is where we are, we have Georgetown Hospital. I'll come back to that just now. Region 5, we do clinics in Maikon. Region 6 is where the National Psychiatric Hospital is. And there, they have sites outside of the hospital where they do outreaches, or they have formal clinics, I should say. Region 7, we do clinics in Article. Region 8, we have not reached there, not that there is no need. Region 9, we do clinics there, as the Latin area. And Region 10, we now have a psychiatrist. At one point in time, I don't want anybody to feel bad, but I was the best psychiatrist in Guyana. Okay? I know some of you wouldn't like to hear that, but I was. I was the only one. So I was the best. Today I'm the oldest. Today we boast of 14 psychiatrists. One in the private sector, Dave Sharma, who should be here later today. We have one in Linden, one in Region 2, which is the study area. We have 2 in Region 6, where National Psychiatric Hospital is. The rest of us are in Georgetown Hospital. Among us today, we boast of 2 child psychiatrists, Dr. Janice October and Dr. Boris. Where are you guys? Without them, I go a little bit more up. Because of the needs, I'll tell you what, we don't have much epidemiologic data. There's very little we have. And with you folks here, it's almost virgin territory. There's lots to be done. And like I said, I'm confident that together we are going to achieve a lot. Even though we have all these services, and we have 2 child psychiatrists, we still don't have beds for children. Okay. When my wards, the 4-bed wards were burnt many years ago, we created a holding area in my tent. We have 7 beds. This holding area has been there for many years. We are still holding. We are holding very strong. We're not letting go. And hopefully, before the year is out, we shall have an extension done. Find it difficult to guide as well. All right. I'll come back to Region 4, Georgetown Hospital. We were assisted by the Dalhousie University at one point in time, 2005, 6, 7. We started doing work. We developed a national mental health strategy. We developed national suicide prevention plan. We reviewed our archaic mental health ordinance of 8th of March 1930. Like I said, in Guyana, we have this thing, I don't want to call it a sickness, just now. So since then, we have been reviewing, and we reviewed it. It went through many stages. It went through 3 ministers' hands. It is only now that we're getting some what we call action. Hopefully this will be real action. We recognize all the shortcomings in the old archaic ordinance. One of them being the criminalization of suicide attempt. All right, and we all talk about that. Our new mental health bill will be much more friendly for patients and the other side, other set of people. Can you imagine that in the courtroom, the file jacket, when it says crime, what they put? Can't guess that. Crime, insanity. It's that far. So yeah, we recognize that. We had done a review with the help of PAHO. And once again, we were slow, so slow in getting things done, that by the time we were ready to go back to it, so many years had passed and PAHO had discarded the damn thing. So we started over again. Right now, we are having a suicide prevention bill being looked at. We hope to get that passed by year end. So things are happening. Things are happening. Now, Dalhousie, and if I speak of Dalhousie, I have to refer to names like Sonia Chehil and Stan Butcher. They did work. They did work. And thereafter, we've been having very close, strong support of McMaster University. And when I speak of McMaster University, I have to make reference to names like Peter Conard, Dr. Peter Conard, Dr. Eric Schrenik, and Reverend John O'Connor. We have been working together. We have been able to develop a postgraduate program in psychiatry, just like how they have the Masters of Medicine in Surgery and Pediatrics, Gynecology, and so on. We have an MMed program in psychiatry. Thanks to all these folks. And it is still going, it is getting better, it is getting stronger. We have so far, we have graduated 4 from the program. We have been working, things have been happening, and then at a certain point in time, sometime around 2014, it's like the gearbox got some problem, and things stopped happening. And by 2015, I don't know if they changed from automatic stick gear or what it was, but things went almost on pause. And we lost a lot of time. We are now trying to get back on track. Now, as Dr. Adu-Krow mentioned, we did do some studies, and I must say that when one person referred to our studies as quasi, I took offense, but then later I understood that he was being quite nice to me. So we did some studies. Between 2003 and 2012, we conducted 3 studies. They had their limitations. However, information gathered, which I'm sure you all have seen, is very, very similar. Now, why is it with more personnel, more services being offered, our suicide rates have gone up? Why? We don't know. Well, you all are going to help us with that. How do we address it? We need your help. We have not been able to address it. All right. Our suicide prevention, National Suicide Prevention Plan, I'm sure it needs lots of work. All right. We are happy that you guys are here. Now, many things we have started, and then for different and for unknown reasons, these things have fallen to ground. For example, we hope to have a psychiatrist in every regional hospital in 5 years. It's happening. And a psychiatrist in every district hospital in 10 years. Between then and now, we had started to train the medics. Medics are the frontline guys. We had started to train the community health workers. These are the people who are making the first contact with the people in the villages. And then that fell apart for strange and for unknown reasons. There is so much to be done. We have very limited amount of protocols, policies, guidelines when it comes to mental health, especially the usage of psychotropic meds. By the time I finish here, I hope you all don't say, hey, we didn't come here for all of that. I hope you say, hey, we got much more to do. That's nice. We have tried to move, with the world and go from institutional to community care. We're doing stuff. Have we achieved much? No, we have not. Our National Psychiatric Hospital, it's a sad place, very sad place. Work has been done many times. Physical structures have been erected. But then, did we accompany that by improving the number of quality of staff? The answer is so we basically have an institution with probably 70% of the people not needing to be there, but they're there living. So we have a psychiatric hospital with about 200 beds and all sorts of patients there. We had a strong plan, a plan to change that whole concept, a plan to make it a national psychosocial rehabilitation center, whatever you call it. And do what? Are we going to put out the patients? No. Are we going to throw the beds? No. The idea was to study each case and classify all these cases, and then create a neuropsychiatric service, psychogeriatric service, substance use, abuse, something, whatever name, service, and a acute care service. And then that alone would have reduced 200 psychiatric beds to probably 60, or 80. And then with that kind of approach, our thinking was that the people would have gotten better care. So that, a few years ago, fell apart. We have a major problem with homelessness and homeless people in Guyana, especially in the towns and in Georgetown. We had a beautiful plan, but a few years ago, the plan was put to rest. I hope that all of you here be able to revive those things, review them, and come up with something, that will suit our setting better, so we can achieve much more. Work has been done, people have benefited, but there's much more work to be done. And whatever stats we have are not necessarily representative of, the reality. Now, it has always been an issue, finance. Financing is always an issue. Is it because we didn't have oil? Well, we are all hoping the oil will trickle down. Let's see. I think it's priority. Priority is whenever, given to mental health. Mental health is getting attention. Mental health has been named among the priority areas just recently. And so there is hope. There is hope. There is hope. What gives me a lot of hope is the fact that we have this person, Helen, Dr. Adu-Krow. He knows Guyana, he understands it. Dr. Adu-Krow is the person who gets things done. He doesn't leave them halfway hanging. He's not a just now person, right? Well, thank you, you're not born here. Maybe that's helpful. He's not a just now person. So I'm quite hopeful. Now, like I said, we have an Orygen territory to work on. Research, very much needed. We have not done research. We didn't have time. We didn't have the person Now we have personnel, so there's more time. Right? I don't know if you all have ever heard of eat well, sleep well clinics. All right, eat well, sleep well, okay. Sleep and go. That's how you sleep 200 people sometimes. Now we are greater in numbers, and we're doing better work. We need a functional plan for the National Psychiatric Hospital. And our mental health plan for a period, plus it is not perfect. We need to, update that plan. And I think PAHO is helping us with that right now. We don't have a forensic psychiatry facility, but we have doctors, psychiatrists who have had some additional training in forensics. I think this is a good time to get this going. I know they're going to do a modern prison. There. Modern prison, modern facilities, and they will have a forensic unit. Right now, what we do is we have the beds in the prison system, and we lodge our cases there. An area where we do need to work is that we need a meaningful mental health component in every existing curriculum, every single one. We need to go to the teachers training center. I know over the last couple of years we did some changes that was 7, 8 years ago, but we need to have more, because the teacher spends all the time with the students. The teacher needs to be prepared. Many of our children, need that help. They wouldn't talk, but you have to be able to pick it up. And so we need to focus on those areas. Every single program should have a meaningful mental health component. All right, because we can't just depend on a doctor or a psychiatrist. We all know that. I think my time is up. I don't know if I've addressed. I can continue talking about psychiatry, mental health in Guyana. Talk all day. I may sound as if I'm complaining. No, I'm not complaining. I'm just saying, okay, we have work to do. We need help to do it. We are very happy that you all are on board. All right. Now, like I said, I was the best psychiatrist. I was the only one. Now I'm the oldest. I am referred to sometimes as chief psychiatrist. That makes it look as if I'm responsible for not doing anything, right? Well, I guess many of the things that we have not done, I have to take responsibility. That's fine, I have to. But what we do need, right, having the commitment from the government, which is key. There are times that you don't get that. Now we are getting it. We have to seize the moment. We have to run with it. All right. We need good mental health leadership. We need to have people who understand and who are willing to go according to a plan. If you have a plan, then you have to use that as your guide, and you have to, move things forward. So we need good mental health leadership. So in spite of the fact that I may have complained a lot, we are doing work, and we are willing to have others come on board, help us define things, move everything, like our national song says, onward, upward, may we ever go. Thank you.
So we have finished the sessions for this morning, and now we will be entertaining questions from the audience and from our colleagues who are online. We can begin with our colleagues within the audience. Are there any questions for Dr. Harry?
What I would have liked to see a lot of statistics on what Dr. Harry was talking about. If we could have seen the statistics of the past years when we had minimum suicide and the years now that we're having more suicide. I think data allows us to set precedents and fix solutions.
In some prior presentation, data would have been presented. And yes, we do have data, but that's why I said I didn't want to repeat stuff that is,
Thank you, Dr. Harry. Not to go. The question is, at what age can mental health illness affect you? It's from one of our colleagues online.
Okay. So once it is that a person has risk factors that are present, risk factors for mental illness, from then is when it is that you can actually start seeing these affectations. So from very young children, adolescents, and as the timeline continues, once it is that we have these risk factors, persons can actually start having mental illness. So these risk factors would be individual, in the family, in the society. So once it is that these things are there, then yes, at any age, the mental illness can appear.
Our next question is for Dr. Harry, but I think Dr. Hoven can also zoom in on this. Are there any research currently being undertaken? That's the first question from Mr. Isaacs.
I do not know. I'm sorry about that. We have several students and residents who are doing research. So research is being done. The level at which it's being done and the sample size and the location, how useful would it be to come to, well, a national conclusion and for you to use to help develop a national plan? I do not know. However, all studies are important and they will give you some information from which you can develop further studies. So studies are being done.
Yes, I wanted to add to what Dr. Harry just said. I think research is being done, at least the ones that I've seen through UG and helping the students. But as Dr. Harry alluded to, they usually represent the population that they look at that you cannot easily generalize because of the research methodology may not be that robust. So I think projects like these, whereby research is undertaken with the vigor that it needs, then one is able to discern what is really happening. So yes, a lot of research have been done, but as Dr. Harry alluded to, there's a need to have more rigid research being done that can stand the test of time, and that's what this project is seeking.
So our next question, Mr. Isaacs is asking, are there plans to complete another WHO AIMS mental health assessment in Guyana? The last one was done in 2008.
Yes, that has to be done. I wouldn't have that information. The mental health unit and the issue health to the CMO's office will have that information. But the answer is yes. It should have been done before.
Our next question is, Are steps being made to increase the number of psychiatrists, qualified psychiatrists in the country, as we currently only have 14, which is way below the number that can have a meaningful impact?
I emphasize the fact that there was one, right? And we had 2, then 3, and now we have 14. I think we need to say, Lord, thank you. Yes, there is intention to have more, and we are going to have more. For a couple of years, I was sabotaged because doctors were not released into my program. They wanted to come to the postgrad program, they were not given the release. Okay, if not, we would have had better prognosis. But we are now stronger, we're doing better, we know how to get things done, and there is no turning back. Okay, there's no turning back. Right now, we have 5 residents year 1, we have 1 year 2, okay, and those who graduated 2 years ago. So we had that problem. That will not happen again. How to get it done. And like I said, in 5 years, we are going to have a qualified psychiatrist in every regional hospital. And in 10 years, a qualified psychiatrist in every district hospital. Okay? Concomitantly with this, we are going to beef up the mental health, the MH-GAP training. We have been having MH-GAP training over a number of years, maybe 10, 12 years. The training, for some reason or the other, has not been effective, or because we are not getting the results. Okay, we are not getting the results. The idea of MH-GAP, we all know, is to bridge the gap. All right, every single doctor is trained. At the beginning of our medical school, the students used to have 1 week in psychiatry. Now we have 2 rotations of 4 to 6 weeks each. So the average doctor coming out of UG Medical School and the other offshore, like PAHO and so, they get much better preparation in the field of psychiatry. They get as good preparation in psychiatry as they get in the other fields of medicine. Because of COVID, things have shifted a little, but they are still being trained. So the average man graduating out there is better geared to deal with mental health issues. We have to go back to what we started. You see, it's not only the psychiatrist, we need a team. The nurse must be trained to do what? Apply some simple questionnaire. There's simple, very simple tools out there that anybody can apply. So if we use these tools and have the clerks and the nurses and the medics and the community health workers and the midwives and everybody in the system trained to apply. Everybody who comes to the health center, it must be applied to them. If the father of a patient turns up, then apply it to the father. Everybody who comes to the health center should have the blood pressure tested, young and old. That's the only way you're going to really be able to make a diagnosis of what we really do have out there. So if we have meaningful mental health component in our curriculum, then everybody will be able to make that contribution at all levels.
Question from our colleague in the audience, please.
Intrigued with your presentation, and I'm happy that you would have mentioned that Guyana has moved in the direction of having 4 psychiatrists in the country. But yet, in my opinion, Guyana remains a neurotic society. My question to you, sir, as one of our leading psychiatrists in this country, would it be imperative for the need, is there a need for a clinical psychologist, since many persons their mental abnormalities might not be due to a general medical condition? And if so, to address the neuroticism in our country, is it imperative to have psychosocial education in our educational system to start addressing these issues at an early age? Thank you.
That aspect, even though it's on my paper there, it slipped me. The answer is yes, 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 and yes. Thank you very much.
To comment, I think I also support the issue of having one psychiatrist in every district. But as Christina pointed out in her presentation, increasing staff alone may get us to a point. There's a need for hard data to guide what we are doing and have a multi-sectoral approach. I think Dr. Lashmi talked about Ministry of Education, Ministry of Security, Ministry of Health, Ministry of Local Government. Everybody will have to come together. We can have the staff and still not get to where we want to get. So we need the staff, but we need that coordinated approach. That's why. The other thing is that I think to Pandit's person, I think we need the psychiatrists, we need the psychologists, we need the social workers, we need everybody. So I think don't let us leave here thinking it's only a problem for psychiatrists. It's a problem for all of us.
Somebody has another question?
Just to add to what Doctor said about the MHCAP, I have been in the WHO in developing the MHCAP guidelines and the intervention guidelines, and we looked at how it has fared in various countries, and it is very, very uneven. Some countries have done extremely well, and some countries the effect is not there. And what we found was that countries like Panama, which introduced the whole MHCAP, not the parts taken. And the most important thing is the continuous monitoring and evaluation which happened. So countries where MHCAP was introduced and there was a continuous system of monitoring and evaluation which was put right from the beginning, those countries have done well. So if you think the MHCAP has not done well here, one of the things which you might look at is to see how there is a continuous monitoring and evaluation, and so that you can contextualize MHCAP to Guyana.
We'll close the question and answer section for the time being, and we will close the morning session.